Hello and welcome to this very special edition of Professor Speaks. I'm young Hugh Hefner, also known as Alex Hernandez. This is a well-known doctor and Dodger season ticket holder, Dr. Craig Stern. All right. Now I mentioned that this was a very special episode, and other than the fact that it's Halloween, it's also our 50th episode here at Professor Speaks. Yay! And our producer wanted me to make sure I get a lot more energy and get the flow going, right? All right, but before we get into the great amount of videos that we want to recap over all these past 50 episodes, but before we get into that, I wanted to go over why we started Professor Speaks. Now, Dr. Craig Stern, he started Professor Speaks, so why don't you go into why this started?
Yeah, thank you.
Mhm.
And thanks for allowing us to be a little comical today, although on a regular basis, including today, we speak about some very serious topics. The reason why I started Professor Speaks was really an outgrowth of what we do with our pharmacy benefit news that we put out every 2 weeks. And that was there is a significant amount of misinformation, frequently disingenuous, frequently lies that are coming out in the media. And unfortunately, it is bleeding over into healthcare. My concern, I think a whole lot of people's concern, is that you can't treat people with a lie. You have to find out what is the best therapy, the best information. You can't lie about it so that someone can get, hopefully, the state of the art therapy at the time. Secondly, is you can't build benefits on a lie. You have to make sure that you have the information, it's correct, and what is going to impact people, whether it's their therapy, whether it's copays, whether it's deductibles, all of that has to be based on truth. So we've taken the position that we're not taking a position as Democrats or Republicans. We're not taking a position as pro or con something. We're not taking a position of a cultural, a religious, or others. Ours is let's just present the facts and let everybody decide what they want to do with it. So that's the rationale. That's why we did it.
Uh, that's a good reason to start it. And some of those facts I want to go over today with some of the episodes, some of our favorite episodes that we've had over this. What is it? It's been since the beginning of this year, right? About
So.
March, April.
Before that.
Oh, even before that, last year.
Okay.
Oh, excuse me. Um, but one of the videos I wanted to talk about and bringing back to our conversation was we talked about the AHCA back in March when Senator Al Franken and other senators brought up the bill. We had this like silly discussion where we thought our representatives were going to find a way to repeal ACA. It seems like such a long time ago, but bringing this topic back around, the ACA is still here, the Affordable Care Act. Repeal failed twice that I know of. I don't know if there was more than that. I'm not sure. And budgeting has stopped almost completely for the ACA, meaning the marketing and advertising for ACA to get people to sign up. By the way, open enrollment starts November 1st, which is tomorrow. So please go sign up. And well, bringing back Dr. Stern. Dr. Stern, as a healthcare professional, how does all this instability and uncertainty, meaning in the healthcare market where we don't know whether ACA is going to stay or whether it's going to get repealed or whole new healthcare is going to come into effect, how does all this uncertainty affect the care of patients?
Well, number one is uncertainty is horrible.
Right.
With regard to healthcare. I'm not talking about whether it's Republican or Democrat. I'm talking about the fact that people depend on knowledge about what kind of healthcare they're going to receive, what it's going to cost, so that they can plan if they're going to go for something that is discretionary, or if they are sick, then they know what this is going to cost. Just like in the financial markets, where uncertainty is very difficult because you may be paying more, you don't know what the probabilities are. Same thing is true in healthcare. From the patient perspective, they could be dealing with benefits that they don't have or maybe no coverage. They could be dealing with areas where they have a greater amount of copay or deductible, because the trend with increasing cost today is to pass more of that along to the member, so they could be paying more in that regard. And care can be where they choose to go to a provider or not, depending on whether they can afford it. From a benefit standpoint, from the plan standpoint, uncertainty also is a problem, because in that regard, you can't identify what kind of a benefit to do. You may have increased premiums, which means once again you're going to shift a certain amount of payment over to the member. And the current estimates right now are that 37% of the premiums are going to increase. So you're going to have premium plus 37% of that, based on all of this stuff that's going on in Congress. And so Congress has led us to an uncertain situation that typically you don't do just on a dime. You plan it, and people have the opportunity to identify what goes on. So this has multiple levels, including providers who don't know if people are going to have benefits. So they don't know whether they're going to be able to follow up with their care. They don't know if people are going to be able to come to them. They don't know if they're delaying because of cost. It goes on several levels: patient, plan, doctor, etc., including hospital, where people are going to have uncertainty as to whether they're going to go to the hospital or otherwise. If they have to go, then there'll clearly be a lot of uncertainty about, is it covered? What are the costs for it? What am I going to pay in copays, etc.? So every person along the line has a problem.
Yeah. Uncertainty has caused a lot of problems, and especially with the healthcare and with it, all these comments. You got people who make a comment for ACA, and then all of a sudden they're determined leftist or Democrat. And it's a hodgepodge, but we'll get into that later. If you have any more comments or questions about it, please feel free to leave it down below. Moving on to the next Facebook video that we've had, or I'm sorry, Professor Speaks video that we had. We also had a conversation about pharma drug marketing, also known as direct-to-consumer advertising, back in April. We talked about why the direct-to-consumer ads are allowed in our market and how other countries have banned it completely. There was some speculations as to the pharma companies patching on the cost of drugs to pay for these advertising. And also we talked about how it is understood that pharma is basically run by ad firm executives or legal teams, as you mentioned. Do we see any of this changing in our future?
Well, at the present time, no. There's nothing in legislation. There's nothing that says that there is going to be a change in pharma. In the pharmaceutical manufacturers, they are generally run by attorneys because there is a significant amount of changes with regard to new regulations, timeframes, etc. So on one level, clearly there are issues with regard to that. And there has been historically an expansion of drug usage after the implementation of over-the-counter advertising for drugs. However, it's not entirely a pharma problem. We're dealing with the fact that pharmaceutical manufacturers are advertising, and the pro-con argument was, on the pro, this will inform people about diseases or medications that they didn't know about so that they'll understand their options. Right. On the con side, there is the argument that says that, well, all you're doing is advertising drugs, so as a result of that, people are going to utilize. Right. So there is a discussion. On the other hand, doctors are prescribing many of these drugs considered from their vantage point to be better than what they had before or otherwise. Right. And there's a certain amount of patient demand. So the doctors and doctor education is part of this as well. And so is patient information, because when they do it, the patient has to understand, what are my options? What kind of other options are there? What less costly options that does exactly the same thing? So this isn't just a pharmaceutical manufacturer argument. It's an argument with regard to physicians that may or may not choose to be prescribing. Right. If it's OTC, clearly they don't have to, but then pharmacists and doctors are involved with evaluating a profile for which the OTC may have drug interactions or other kind of influences on what goes on in prescribed drugs.
Right.
The doctors clearly need education and understand what the options are and what the costs are. Years ago, doctors didn't care about what the drug cost is. Today, in general, they have to
You have to take it
because
into account for the
people have
patient.
to know that, or the patient may not take the drug because they can't afford it.
Right.
And finally, there are issues with regard to patients, or maybe not finally, but clearly there's a lot of people involved in this.
Right.
But patients are involved too because they need to understand what their options are, what their cost differentiation is as well. So yes, it is a pharma problem, but it's a prescriber problem, it's a patient problem, it's a lot of other, it kind of rolls through the lane as to which one is involved.
Right. Right. And decreasing the demand for these drugs is also huge, I guess, in patient doctor relationships
Yes.
and understanding um, preventable problems that could occur.
Yes.
We also had a special all women panel to discuss the topic of women's health back in June. It ranged on various topics such as abortion, contraception, and even mental health. This was important for our company because having men speak on the women's health issues felt somewhat irresponsible on our part, and not only as men but also as consultants. And Dr. Stern, would you like to comment on that?
Yeah, let me just make a quick comment on it. We did this originally because there were concerns in the debate over healthcare as to whether certain services were going to be included or not included.
Right.
But it's a bigger issue than that. The real issue here is the following. Healthcare, whether it's by design or whether it's prescribed, is for all people. It doesn't matter whether it's men or women or people of different genders or people of different religious types or cultures or otherwise. At the end of the day, it doesn't matter. We treat everyone. And so problems that women have, whether it's going to be covered or whatever their women problems are, in a very broad sense, are not just women problems. They're men's problems as well and everybody else's. Because whether it's a prescriber, man or woman, whether it's someone who is using it, man or woman, whether it is education about what their options are and what can they do. This is not just men, women, or otherwise. It's that healthcare is designed to treat all patients.
Right.
Benefits treat all patients. And so we have to look at this in a general way. Yes, we wanted the women to talk about it because it makes sense for that. But we can't disregard the fact that men are involved in this process too. Everybody's involved. Medicine treats patients.
Right, right. And the women did a fantastic job, so please feel free to go back and revisit that topic. Now, this topic has recently come back around. Back in May, we talked about opioid abuse and what contributed to this epidemic. The contributions are important, and you can look up the video that we did back in May. But also, there are various articles written by LA Times and New York Times in full detail about this opioid epidemic. And but Dr. Stern, what has happened since we last talked about this problem?
Probably the biggest thing that's happened is more people are talking about it. This is not a quick fix. It's not something where you can throw a drug. Clearly, people are using naloxone and buprenorphine in order to try and treat people who overdose.
Right.
But that's treating the problem after it's occurred. The problem has to be addressed before it happens.
Of course.
And so the CDC has offered guidelines. There's been further education about it. But at the end of the day, this is not a silver bullet that you do this and you fix the problem instantaneously.
Right.
This is something that's going to go on for a long time. And what we've seen is that there's further dialogue, further education, more emphasis on it. And so whether we're successful or not will happen over time. And what we do will happen over time. The hope, of course, is that chronic, non-malignant, non-cancer pain will be treated appropriately and will be limited in its extent. And second, chronic malignant or cancer pain will be treated. But we also have to recognize the fact that drugs are not the solution for the problem. Right. They are one of the elements of treatment, without doubt, and they're very important, and they work. Yeah. But they're also part of a total armamentarium that includes behavioral processes in order to help with the process, potentially in some cases with regard to pain, physical therapy and chiropractic and other modalities that will be brought in order to deal with this, because drugs don't solve this problem.
Right. Throwing drugs at the problem only begets more problems.
That's correct.
Usually.
That's correct.
And finally, back in August, we talked about hospital costs. With healthcare costs being high and the fact that the cost of care and services varies between hospital to hospital, you had mentioned in the video that there is not a big push to regulate these costs or to try and keep the costs down. Is there any way we as citizens can change that in the future, and should we?
Well, let's focus on hospital for a moment, since you've asked that particular, and then we'll expand it.
Okay.
The issue here for the hospital is that the only way to really control the hospital costs is for hospitals to be cognizant, try and find more efficient, less costly ways of delivering care. Mm-hmm. Today, hospitals have become more intensive care units than they have residential areas. And so as a result of that, the types of therapy, the types of drugs, the type of surgeries, etc., become paramount. Mm-hmm. With the intent of trying to control what's going on. And the only way to really make that aware is for the hospitals to be aware and for people to do comparative shopping so that they can identify what the comparisons are and effectively put it into a market mechanism, right, which was part of managed care in the first place.
Right.
And hopefully that is one way to address it. The second way in the hospital setting is to implement and discuss more efficient methods of moving a patient through the process, dealing with potentially more technology that makes the surgeries less invasive and less use of general anesthesia in order to try and get it. That's already happening, right, with laparoscopic procedures and things where you do get anesthesia, but it's not the general anesthesia that takes a very long time to respond, mm-hmm, a very long time in convalescence, etc.
Okay.
On the outside is the other problem, and that is we need to pay attention, and we are, to a degree, paying attention to an outreach to patients on the outside to make sure that they're being taken care of on the outside, mm-hmm, so that their problems don't become so bad that they have to go into the hospital. And in the hospital, making sure that there's a transition to whatever they do on the outside so that they don't bounce back and we don't have these avoidable kind of medical conditions. So clearly, the hospital is the focus here, is what you've talked about, right, but the hospital has a bigger image today. It has an umbrella over what's happening in its community in order to try and prevent a lot of the admissions, has an umbrella to those people that have left and how you go about controlling that everybody knows what they're on, everybody has a set plan for it, and that there is a good coordination of care happening between the hospital and the patient. When we do all of that, mm-hmm, then there'll be improvement. And I think slowly the entire profession is moving in that direction as we address it.
Is that just an improvement of cost or an improvement of quality of care?
Well, I think it's both.
Okay.
The hope is that quality will lead to lesser cost. In
right,
healthcare, there's always been an axiom that in technology, in retail, etc., when you get something new, it improves the quality and it lowers the cost. In healthcare, you've got something new, it improves the quality and the cost went up. Mm-hmm. So healthcare has to address the problem, right, that is it necessary with some of these new advances that the quality has improved, but the cost is going up, and finding a way to cut the cost while we're doing that. It's not a trivial problem, but moving, for example, from general surgery to laparoscopic surgery, where there's quicker surgery, shorter convalescence, etc., allows us to try and find ways to control over cost. And that's just one example.
And another way to keep hospital costs down is by staying off of these. Now, I did mention that it's Halloween, and Dr. Stern himself has a hard time laying off the candy. But we also got to do a good job of preventing hospital visits by exercising, eating right. And instead of this bowl of candy, it should be a bowl of carrots and broccoli. But what are some other tips that we can share with the viewers as well?
And as I've said to many, including everybody on the staff, there's probably nobody who likes candy more than I do. You may like it equally, but probably not more than that. But the reality of this is that while it is Halloween, it's a great holiday. Who can argue with people going around and people giving them free candy? It's just wonderful. But at the end of the day, there are complications, and clearly issues with regard to the complications of higher sugars. And clearly we also have drugs, or maybe not so clearly, but we do have drugs that treat the problem.
Mm-hmm.
What we've done, however, is something that we've done with surgery, something that we've done with drugs, and that is, to a degree, we've made things too easy. We've given drugs that lower blood sugar,
Mm-hmm.
and as a result of that, it's kind of easy. I kind of abuse it, I overdo it, and I can take drugs and I can lower it. But at the end of the day, this doesn't solve the end organ problem, because it's not about just lowering the blood sugar, it's about dealing with the end organ problem. And so to do that, what we're talking about is you have to deal, as Alex is talking about, with preventive techniques. It seems simple, it's hard to do, but it's terribly important. And that is, drugs don't solve the problem. They help lower the risk of the problem.
Right.
And so in this regard, prevention, weight loss, dietary habits, exercise, all of these are terribly important, including stopping smoking, to make sure that you're dealing with the fundamental problem in the end organ disease, not just because it's easy, not just because it's easy that, well, I ate too much, therefore I can have a drug, and therefore everything is okay. It's not okay. It's things that we have to pay attention to. And yes, it's hard. If it were easy, everybody would do it. There wouldn't be a need for drugs. We'd already have the problem. So in that regard, consider that, because drugs make it easy, but the problem still exists. We have to be able to control it, and that requires prevention.
Right. Well said. And that's all for our very special Halloween 50th episode version of Professor Speaks. I am Alex Hernandez. I'm not Hugh Hefner. He is not even a Dodgers season ticket holder. And so please visit ProPharmaConsultants.com. Remember to visit our RxInfoX page, and we also have a Professor Speaks tab that has a long catalog of all of our episodes here at Professor Speaks. And please feel free to leave comments, messages, and we will see you next week.